Endometriosis affects millions of women and people assigned female at birth, and it's often misunderstood. It causes severe pain, fatigue, and in many cases, infertility. This isn't just bad period cramps. It's a chronic medical condition with far-reaching impact. Scientifically, endometriosis is when tissue like the uterine lining grows outside the uterus. These implants can appear on ovaries, fallopian tubes, bladder, intestines, or the pelvic lining. They behave like endometrium, thickening, breaking down, and bleeding each cycle without a way out. The trapped tissue causes inflammation, scarring, and adhesions. That can lead to chronic pelvic pain and organ dysfunction. Symptoms vary widely and don't always match how much disease is present. Myth: endometriosis is just bad cramps. Fact: pain can be debilitating and is not limited to menstrual days. It can disrupt work, relationships, and life plans. Myth: you can't have endometriosis if you're young or haven't had children. Fact: it can affect menstruating people of all ages, even teenagers. Early recognition matters for better outcomes. One leading theory is retrograde menstruation. Menstrual fluid flows backward through the tubes. That deposits endometrial-like cells outside the uterus. But this explains only part of the picture. Coalomic metaplasia suggests certain cells can transform into endometrial-like cells. Genetic or environmental triggers may prompt that change. Research continues to investigate these mechanisms. Some evidence points to immune system dysfunction. The body may not clear ectopic tissue. Immune differences could let lesions survive and grow. This is an active area of study. Another idea is vascular or lymphatic spread, cells traveling to distant sites. This may explain rare implants outside the pelvis. No single theory explains every case. Certain factors increase risk for endometriosis. Family history, especially first-degree relatives, raises risk. Early menarche, before age 11, is another risk factor. Short cycles under 27 days and heavy or prolonged periods are linked to higher risk. Never having given birth is also associated with increased risk. Higher lifetime estrogen exposure or endocrine disruptors may play a role. Symptoms vary widely, from mild to life-altering. Pelvic pain, especially during menstruation, is common. Chronic fatigue often accompanies the pain. Pain during or after sex, dyspareunia, is a common symptom. Painful bowel movements or urination, especially during periods, can occur. Bloating and gastrointestinal symptoms are frequent. Heavy or irregular menstrual bleeding may be present. About 30 to 50% of individuals with endometriosis may face infertility, but many conceive naturally or with treatment. Diagnosis is often delayed, on average 7 to 10 years from symptom onset. This reflects symptom normalization, low awareness, and diagnostic limits. A thorough medical history remains the first step. A pelvic exam can find cysts or nodules but may miss deeper lesions. Transvaginal ultrasound can detect ovarian endometriomas but not all lesions. MRI helps map deep infiltrating disease when needed. Laparoscopy is the diagnostic gold standard. A camera visually confirms lesions. Surgeons can biopsy and often remove lesions during the same procedure. Excision surgery offers the best symptom relief and fertility preservation in many cases. There's no cure, but treatments manage symptoms, slow progression, and protect fertility. Hormonal therapies can reduce or stop menstruation to limit lesion activity. Options include combined hormones, progestins, and GnRH agonists or antagonists. NSAIDs help with inflammation but are often insufficient alone. Multimodal pain management may be required. Pelvic floor physical therapy can provide meaningful relief for some. Laparoscopic excision removes lesions and reduces pain. It's more effective than ablation alone. Hysterectomy is a last resort and won't always resolve symptoms if implants remain elsewhere. Treatment must be individualized to age, symptoms, and fertility goals. Holistic approaches, anti-inflammatory diet, omega-3s, and supplements may help symptom control. Yoga, meditation, and acupuncture can complement medical care. Psychological support and therapy can mitigate the mental health burden. Living with chronic pelvic pain can lead to anxiety, depression, and isolation. Medical gaslighting and dismissal deepen distress for many. Acknowledgement and compassionate care are vital. Endometriosis can affect fertility, but many conceive with help. Options include surgery, IUI, and IVF. Discuss fertility goals with your care team. There is hope and real support available. Support groups, advocacy organizations, and online communities offer education and solidarity. Reach out to groups like local endometriosis foundations for resources. Connecting with others reduces isolation and empowers advocacy. See a clinician if pelvic pain or heavy periods disrupt your daily life. Document your pain, cycle patterns, and family history before visits. Persistent symptoms deserve thorough evaluation. Insist on answers. Ongoing research is improving diagnosis and treatment options. Public education and advocacy are changing the narrative. Awareness saves time, pain, and futures. Quick recap: pain is not normal, seek care, and know you're not alone. Book a consultation and track your symptoms. Reach out to friends, providers, or support groups for help. Early diagnosis, individualized care, and compassionate clinicians can make a life-changing difference. Check the description for resources and links to support organizations. You are not alone. Share this video to help others find answers.